Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha. I am a nurse here at UWorld, and we know we are in the beginning of the school year. The weather is hopefully getting a little bit cooler, so we're going to try and hit a really important, really prevalent topic. We're going to talk about common pediatric conditions. So as the weather gets cooler, as we move into cold and flu season, RSV is a big thing on everyone's mind. We're also going to talk about strep throat, and then we're going to cap the lecture off with head lice because it's not a pediatric lecture, unless you talk about head lice. So a couple of housekeeping things before we get started. We really take into account the topics that you all want to see. Drop in the chat the suggestions you have, the body systems, the maybe pharmacology topics that you want to see us present on. After all, we are here to help you guys, so let us know how we can best do that. We're going to have questions sprinkled throughout today's videos, as well as NCLEX style questions to test your knowledge at the end, so make sure you stay tuned and don't miss those. Follow us at UWorld Nursing on whatever your preferred social media channel is, so you don't miss any of these lecture sessions or question drills in the future. We are also so close on our TikTok and our YouTube channel to hitting 100K followers. So please drop us a follow if you haven't already. We put out lots of free content, and we would love to make sure that you guys are not going to miss any of it. So you all know this live will be on demand on all of our social channels after we're done. So if you have to jump out early, if you have to come back in, no worries. We can always use it as the live on demand as a reference in the future. Drop your comments, your questions into the chat. Our content experts are monitoring, moderating the chat, ready to answer your questions. So let's get that chat going by letting us know where everyone is joining from. Who here is a US viewer? Who is an international viewer? Let us know. Alrighty, so looking at this agenda, again, we have 3 pediatric topics: RSV, strep throat, and head lice. So let's get started with RSV. So we're going to start with bronchiolitis, or RSV, which is going to be short for respiratory syncytial virus, an extremely common viral infection that's going to affect so many of our little kiddos during cold and flu season. If you happen to ever be in the pediatric ER during those colder winter months, so much of what you're going to see is RSV related. So what happens here with RSV? First of all, it's a very communicable disease, meaning it's very catchy, essentially. It's spread by those respiratory droplets by direct contact. So like child to child, or even through indirect contact, like a child touches a toy and then another child picks that toy up and then they contract the virus. So think sneezing and coughing when you hear about these droplet precautions. In our lungs, we have those really small tubes called bronchioles where air passes through. Bronchioles are going to be the smallest branches in our airway. So in RSV, these bronchioles get inflamed and mucus secretions increase, making it harder for air to pass through. It's going to make it harder and harder for air, for these clients to breathe. So when we think big picture, RSV, it's all in the name, respiratory. So big picture, our biggest implication is going to result in respiratory distress, and viral. So we know that our treatment here is likely going to be supportive. Now, before we get into risk factors, one quick note is that RSV is diagnosed using that nasopharyngeal swab, same as those original COVID tests. If you remember these, very unpleasant, especially for our pediatric population. So we're going to have to use some therapeutic interventions and communication if we're going to be using that nasopharyngeal swab on a younger client. So what are our risk factors for RSV? We know that it affects our youngest population, but it can also affect our oldest population. So the biggest risk factors for contracting RSV are our infants 6 months and younger, which we know, but also our elderly clients are also at a risk for RSV, as well as contracting complications from that RSV. So it's going to affect anyone who is immune compromised. So think about clients that are undergoing chemotherapy or maybe on immunosuppressant medications. Also think about those clients that have underlying pulmonary conditions. So cystic fibrosis, maybe an asthma. Those lungs are already compromised in this situation. So when we introduce that worsening inflammation from RSV to the airway, it's going to lead to big problems, big implications for these clients. Also, kids that are exposed to secondhand smoke are at a risk for complications from RSV. When these pediatric clients are around smoke, the inhalation of that smoke is going to cause inflammation in the lungs. Similar to what we said about the clients with existing lung conditions, when RSV enters the body and causes worsening inflammation on top of existing inflammation, these clients are more likely to have complications present themselves. All right, so moving right along to our clinical features. And again, we have a table here displayed. So any of these visual references that we put up here for you guys, you are free to screenshot, take them with you, use them for your future studies. But when it comes to our clinical features, the severity of these are really going to vary. Some pediatric clients are going to have pretty mild cases of RSV, and unfortunately, some are going to get really severe cases where they need to be hospitalized. The onset of RSV varies, but typically we see symptoms peak around day 5, with really day 3 to 5 being the worst. This is where these clients are most likely to need hospitalization. So symptoms can be as mild as runny nose, cough, sneezing, fever, and a sore throat. But over time, these can worsen to where we start to worry about the A and the B of our ABC. So our airway and breathing really become big concerns. We can differentiate RSV from that of a common cold because typically the symptoms from a cold only really appear in our head, especially at the beginning. We have that stuffiness, that pressure, but with RSV, the symptoms really present themselves in the lungs. So that's kind of a good way to, in a preliminary sense, differentiate between the two. Now in a second, am going to pull up an image for you guys, not quite yet. So I want you guys in the chat, before we pull this up and give you the answer, I want you to drop in the chat, what does respiratory distress in a pediatric client look like? So what are some things that are going to clue us into our pediatric clients in respiratory distress? Now, this is so important because our youngest clients do not have the ability to verbalize what they're feeling, what they're experiencing, and what their symptoms are. Our youngest infants, our little toddlers who can't yet talk yet, are not going to be able to reliably relay their symptoms, so we have to know what to look for in order to assess and observe it ourselves. So what are some, again, respiratory distress in a pediatric client? I already see a lot of great answers. I see grunting. That's such a good answer. Way to go. That is Duchess on TikTok. This is so important, especially for our youngest infants are really going to present with grunting. We're going to see nasal flaring. Great job. Use of accessory muscles. Retractions. Way to go. Low O2 set or hypoxia. That's a good one. Again, I see more of the right answers. So way to go, you guys. You are absolutely on track. So let's pull up that labored breathing image. Again, feel free to screenshot it. Take it with you. So what does RSV look like upon respiratory assessment? It's going to look a lot like this image that we have pulled up for you all. We're going to start to see those signs of respiratory distress, the signs of hypoxia or low O2 sat. So starting out with respiratory distress in a pediatric client, a lot of times this looks like a couple of different things. We're going to see adventitious lung sounds. So we're going to be auscultating those wheezes, not weasels, excuse me, and crackles. Wheezes happen when air has a narrowed path to travel, almost like a whistle. So this makes sense with that inflammation that RSV causes. It constricts that airway, and this is going to result in wheezes. Crackles happen from fluid or those increased secretions that we see in RSV. They kind of sound like bubbles popping to me, but these sounds again are due to the inflammation of the airway that causes the wheezing, and the increased secretions are going to cause our crackles. We're also going to see use of accessory muscles, which is an option I saw you all drop into the chat. We're going to have essentially the body engage other muscles that aren't typically used to breathe because the lungs need a little bit of help. They need to call in their buddies. They call in those accessory muscles to help move more air through the lungs because the lungs are sick and they're tired and they're not able to do it all independently anymore. We're going to hear grunting, which is another thing I saw dropped into the chat. Way to go, you guys. But especially in our youngest clients, in our infants, this is really something that clues us into labored breathing and respiratory distress. And we're also going to notice retractions, especially when we look around the ribs, the neck, the sternum, and the abdomen. So retractions that happen in between the ribs are referred to as intercostal retractions. Those that happen below the ribs, where the ribs meet the abdomen, are called subcostal retractions. And lastly, lastly, right above the neck here, kind of in that shoulder clavicle area, we'll see those suprasternal retractions. Other signs, another one I saw mentioned is nasal flaring. You guys were spot on with that, as well as tachypnea or an increased rate of breathing. And of course, hypoxia. When we take those vital signs, we're going to see a low O2 sat, so something that's less than 90%. All right, so our last part is going to be nursing interventions. We talked about everything that can go wrong. Now, what can we as nurses do to help these clients? We're mostly going to focus on interventions for those moderate to severe clients, the ones that are going to come in and need to be admitted to a hospital. But first things first, we always want to prevent the spread of infection. So we need to enact our droplet contact precautions. So contact precautions for droplet infection are going to include typical gown, gloves, and mask. We don't need that N95 because this is not airborne. It's just the droplet. So think like a sneeze versus airborne, which is going to be just spread through breathing and talking in the air. So now that we are dressed and ready to care for this client to prevent the spread of infection, we want to focus on supportive care, which is a lot of what we do for our viral infection clients. So this includes administering IV fluids to keep the client hydrated. Fluids and keeping the client well hydrated also helps to thin secretions. And remember, we have increased secretions when it comes to RSV. We want to monitor our O2. We want to keep them over 90 ideally, and we want to apply a warmed and humidified oxygen to help further break up that secretions with the humidification, but also the warmth of that will help to open up and relax that airway and hopefully soothe some of the inflammation. These clients will likely also have very high fever, so we want to give an age-appropriate antipyretic like an acetaminophen or a Tylenol. Now, we don't give aspirin to our pediatric clients with viral illnesses. And my question to you is why? Why don't we do that? What is the reason? What are we concerned about here? I'll say it again. Why don't we give aspirin to a pediatric client with a viral illness? And I'll give you a few seconds to answer. You guys are doing fabulous today. And I already see lots of correct answers. Way to go, you guys. It is Ray's syndrome is what we are worried about. So Ray's syndrome is associated with taking aspirin while sick with a viral illness, and it's really common in our pediatric clients. So we're not going to give an aspirin in this case. We're going to give a Tylenol or an acetaminophen, which we know is a fever reducer, and it's safe to give in our pediatric population. In with the acetaminophen, out with the aspirin. So we want to make sure we also put them in a position that promotes airway clearance. So think about 30 to 40 degrees of elevation with that neck midline and slightly extended. Now, this positioning is especially important for babies who may not yet have the ability to control their neck and head. We don't want them to be all smushed up where they may not be able to kind of level out and extend that neck. So we want to make sure we position them, again, midline, neck extended, so that airway is nice and long and open, which promotes, airflow and not having them kind of smushed up and doubled over. We want to do frequent suctioning on these clients. Chances are these pediatric clients will not like this. So it's a great time to use some of that age-appropriate communication. For our littlest infant clients, we may want to swaddle them prior to suctioning. For toddler clients, we may want to explain to them what we're going to do, let them touch part of the equipment, a non-sterile part of the equipment, and swap it out for a clean one before we suction, just to let them know what we're going to be using, what we're going to be doing, and why we're going to be doing it. These clients need suctioning because they're not going to be able to clear all these secretions themselves. Again, our pediatric clients don't have the strongest of lungs. They're not full, strong, grown adult humans yet. So we need to kind of give them a little bit of a head start, so to speak. We also want to monitor our I's and O's, our intake and output, to make sure this client is not getting dehydrated. Again, they're going to have a fever most likely. They're probably not going to be eating and drinking as much. So by monitoring those I's and O's, we're going to make sure they're not getting dehydrated. In our smallest infant clients, this will look like weighing and counting diaper counts. We want to monitor activity level as well, especially for our youngest clients that can't convey their symptoms. We want to look for signs of decompensation. So these kids, these pediatric clients, are pretty resilient, but when the body has had enough, when the lungs have had enough, you're going to know when something isn't right. They may become listless all of a sudden, have a sudden decrease in activity level. These are our signs of decompensation. And lastly, monitor for any type of secondary infection. Whenever we have increased secretions, that thick mucousy secretion is a breeding ground for bacteria. So it's going to be a really big risk for things like pneumonia, as well as acute otitis media or those ear infections. All right, great job, you guys. That sums up RSV. Let's move on to streptococcal pharyngitis, also known as strep throat. So strep throat is a bacterial infection. We just talked about RSV, which we know is viral. Strep is bacterial. And at the end of this lecture, we're going to talk about lice, which is a parasitic infection. So we're hitting pretty much everything except for fungal infections today. Strep throat is a bacterial infection of the throat, another really common pediatric illness. We're going to see this spread really quickly throughout schools or daycares. It's caused by the Streptococcus pyogenes, which is a group A beta hemolytic Streptococcus bacteria. It's going to be diagnosed using a throat culture. We can use a rapid strep antigen detection test, but we always want to perform diagnostic testing for strep throat, but it does have several key and distinct features that help clue us into what's going on, which leads us right into our clinical features. So what does strep throat look like? Our clinical features here are going to include that abrupt onset of sore throat. Maybe the kid feels fine in the morning and all of a sudden after lunch that throat starts throbbing and hurting. It might look like redness in the back of the throat. Clients can have swollen tonsils that even have exudate to them. They may have palate petechiae, which are those pinpoint red spots on the palate. I also think that petechiae is just kind of a fun word. Clients will, of course, see fever. We can see anterior cervical lymphadenopathy, which is those like increased kind of like swollen lymph nodes, especially in the front. And big pro tip for these kids, sometimes they're going to present with atypical symptoms. So they may actually present with an upset stomach from the bacteria that's actually making its way down to the stomach, causing GI upset. So the tricky part about peds is that kids present so differently than our adult clients with so many different things. So by knowing these little tips and tricks, it can help to clue us in a little bit quicker on what's really going on, because kids can't always reliably convey their symptoms. All right, so let's take a detour from our clinical features and talk about complications of untreated strep throat that are really unique to strep throat. But some of these can be caused by any of that strep bacteria just in general. There's lots of different types of strep bacteria. So a couple different particular complications to call out. The first up is a paratonsillar abscess. So this is something that just means an abscess on the tonsil. It's all in the name, but it is an emergency because they can grow large enough to actually obstruct that airway. These clients a lot of times present with fever and chills. They can have that really terrible pain that's bad enough to the point where they don't want to eat or to swallow liquids. A lot of times they can even have a muffled voice because the swelling of the tonsil is so big, it can deviate that uvula. Our next complication to talk about is going to be rheumatic fever, which can take about 2 to 3 weeks after the strep infection to surface. But again, this happens from untreated strep throat. These pediatric clients aren't going into the doctor, they're not getting antibiotics, and therefore it just like goes on to infect other parts of the body. What happens here in rheumatic fever is that antibodies against the strep bacteria develop and attack healthy tissues in the heart, in the joints, in the kidneys. So what we worry about most is something called pericarditis, which is inflammation around the heart. We can also see joint pain and chorea, which is that involuntary muscle movement. This can become very serious. All right, our next is acute post-streptococcal glomerulonephritis. I dare you to say that 3 times fast. But again, this is from untreated strep throat. It essentially is the invasion of that strep bacteria all the way down into the kidneys. It's going to manifest a lot of times as peripheral edema from impaired kidney function. It's the same idea as an adult that was facing an AKI or an acute kidney injury. Other manifestations we'll see is hypertension, and notably we're going to see Coca-Cola colored urine. So that really dark urine, which is distressing to see, but this dark urine is essentially a color variation of hematuria, which is blood in the urine, but instead of frank dark red blood, it's just going to be dark. Alrighty, and our last complication of untreated strep throat is scarlet fever. This always reminds me of Little House on the Prairie because Mary gets this if you ever watch that, but it's going to present as a sandpaper-like rash. We can see a strawberry tongue and have like beefy red and papules that it looks like a strawberry. That's why they call it strawberry tongue. But again, it's from untreated strep throat. This was very dangerous in the olden times. Again, I talked about Little House on the Prairie, but again, these are the 4 biggest complications we see from untreated strep throat. And it's so important that these kids go in and seek medical attention, get an antibiotic. That way they can prevent this from happening. All right, so our last parts of strep throat are our nursing interventions, the nitty-gritty of what we're going to be doing. So typical medications for this is going to include antibiotics, no shocker there. And before we move on, drop in the chat, what antibiotic do you think we give for strep throat? What is the most common antibiotic given for strep throat? All righty, drop those answers in the chat. I'll give you a few seconds. Alrighty. I see lots of great answers, and yes, you guys are spot on. For our clients that do not have a penicillin allergy, we're going to give them penicillin. So for those with the penicillin allergy, we may go down the route of like a cephalexin, but we do need to offer supportive medications like an antipyretic to reduce the fever. We're going to give analgesics to reduce some of the pain associated with this. We're going to teach the client about consuming soft foods, cool liquids that are going to be soothing for the throats. Other comfort measures include a humidifier for the client's room. That humidified air is going to be more gentle on that inflamed, irritated airway. We can also gargle with warm salt water. This helps to reduce the pain. The solution of salt water will also help with inflammation, and that warmth is going to help kind of soothe that inflammation and that irritation. We're also going to do some very important teaching. Now, really important whenever we're talking to our pediatric clients, a lot of our teaching is going to focus around their caregivers or their parents because they're the ones really calling the shots here. But first, we need to teach that caregiver this pediatric client is considered contagious until 24 hours after starting antibiotics, in most cases that penicillin. That means that we need to keep them home from school, typically until they've at least been fever-free for about 24 hours. Is another good rule of thumb. We want to tell that caregiver the need to discard the toothbrush 24 to 48 hours after starting that antibiotic because we don't want them to get reinfected later. Alrighty, so again, teaching is such an important part, especially in our pediatric population. We need to make sure we're including those caregivers. And our last topic for today, I think this is the easiest one that we've covered. Strep and RSV can be kind of dense, but you guys have done a great job. We are going to cap it off with lice, head lice. So we're going to talk about pediculosis capitis, which is a rite of passage for nurses. Lice is a very contagious and parasitic infection. So again, we talked about RSV at the beginning. That's a viral infection. We moved on to strep throat, which is a bacterial infection. And now we're going to cap it off with a parasitic infection. So lice is spread through contact. It can be direct, meaning like from a kid to a kid, or indirect, meaning a kid uses a hairbrush, puts it down, another kid picks it up and uses it, and now they're infected with lice. So let's walk through the process of lice. A female lice will lay an egg, which is called a nit, on the hair shaft pretty close to the scalp. Over the course of about 2 weeks, the nits develop into adult lice and then go on to lay their own eggs, and the process continues until we treat the infection. But you can see how this has the potential to get really out of hand until we treat it. Without treatment, again, the lice multiply very quickly. It's most commonly seen in our school-age children and in childcare facilities where, again, these kids are in really close contact with one another. So clinical features for lice, pretty straightforward. Itching. These kids are going to be itchy. They're going to have severe itching, or that pruritus as we call it. Scratching on their heads can lead to excoriation on the scalp, which is a risk factor for a subsequent skin infection. Whenever we have a break to a skin, we're worried about an opportunistic infection making its way in there. The nits can sometimes be seen behind the ear, maybe at the nape of the neck. What they look like is just a light colored speck on the hair, but pretty much itchy scalp, visible lice are our biggest manifestations of lice. So last but not least, the trick to lice is in the nursing interventions. I will also say nursing interventions for lice are a great place to draw NCLEX questions from. So definitely something you want to pay attention to. In a healthcare facility, we always want to cover up and protect ourselves before we help the client. At a minimum, typically, it's going to be facility specific, but at a minimum, we want to make sure we put a gown and gloves on. In reality, especially if you have long hair, you're going to want to tie your hair up and at least put a surgical cap on to protect yourself from contracting lice. Next, we're going to instruct the client or assist the client in applying a pediculicide shampoo, which is like a 1% permethrin, to the scalp. we need to tell the client or the caregiver to leave this on for 10 minutes. Then we wash the hair in the sink to decrease skin exposure when we're washing everything out. So we don't want to go in the shower where those lice can just wash down to other areas of hair on the body. We want to make sure we do it in the sink and kind of isolate that head area. We also want to wash with warm water, not hot water. So bad news for all of us who love a hot shower, but we want to make sure the warm water doesn't vasodilate as much as that really hot water is going to, because we want to prevent systemic absorption of this permethrin medication. After shampooing, we're going to run through that hair with a really extra fine tooth comb to help remove any of those nits that are extra, tenacious and stay on. And most importantly, we need to repeat this process about 7 to 10 days after the first treatment to treat any newly hatched lice. So the caregiver should also soak any infected hairbrushes in hot water for 10 minutes to disinfect them. Lice travels really quickly, especially in households. So tell the caregiver to check other members of the household as well as themselves. In terms of the house, carpets need to be vacuumed. Mattresses and upholstered furniture need to be vacuumed as well. We need to wash bedding in hot water, dry it on the hottest setting, and any non-washable item will need to be put in a bag that seals for 2 weeks to suffocate those lice if we're not able to put them in hot water to kill them that way. We want to make sure we keep the client's nails trimmed short to prevent that excoriation of the scalp, preventing those breaks to the skin, which can be a risk for secondary infection. And our last point with lice is to make sure we're employing our therapeutic communication. This can be isolating, it can be embarrassing, especially in our pediatric clients. So make sure we're not making our client feel more isolated. We don't want them to be embarrassed. So keep an eye out for any type of question and make sure we're using our therapeutic communication techniques. So great job, you guys. That was a long lecture today, but you did fabulous. Let's go ahead and test our knowledge with some questions. All right, so we have one question for each of our big, 3 points today, which means we have a bonus question because normally we only do 2. But first up is RSV. So the nurse is caring for an infant with respiratory syncytial virus, or RSV. Which of the following findings would the nurse expect to observe? Select all that apply. Our options are fever, tachypnea, poor feeding, sunken fontanelles, or tearless crying. Drop those answers in the chat. Let us know what you all are thinking. I'll give you a few seconds. Alrighty, and I see some great answers coming in. Alrighty, so for anyone who has not joined us for an NSNA webinar yet, it is a great chance. They are, we sponsored them through the NSNA, who we are the official test preparation platform for the NSNA. Our very last one of the year is coming up on Monday, October the 6th. We do 6 throughout the calendar year. This is 6 of 6, our very last one. It is so wild how quickly this year has flown. But if you're not able to join us at maybe one of our lives, we're going to be covering myocardial infarction as well as exam strategy topics. So again, 10/6 is the last chance to catch an NSNA webinar. You can find more information on our social media or on NSNA's social media. We do have big presences at the NSNA Fall and Spring Conference. The spring was in Seattle, the fall will be in Columbus. But if you're unable to travel for that, the webinar is a great way where we can bring this great information to you guys live on your own laptops so you don't have to hop on a plane or take a road trip. Alrighty, I see lots of great answers and almost all correct ones. 1, 2, and 3 is what I was looking for. So this was a little bit tricky. Let's talk about it. We know we're going to see fever. We know we're going to see tachypnea or increased rate of breathing. We can also see that poor feeding. So if you think about it, if a client has RSV, they're struggling to breathe properly. If you're not able to get air in, you're definitely not going to want to eat. So this kind of intuitively makes sense. Now, sunken fontanelles seem to get a couple of you here. This is kind of confusing. So important to note, we are looking for our expected findings. Which following findings would the nurse expect to observe? We're not looking for further down the line complications. So in this case, sunken fontanelles is a sign of dehydration. Now this can result from RSV, but it's a later complication down the line. It's not a direct result of that RSV. So that was tricky, but most of you guys did not get tripped up. Way to go. And lastly, tearless crying was an incorrect option. So good job, you guys. Question 2. The nurse in the clinic has saw a client with newly diagnosed streptococcal pharyngitis. Which of the following statements by the client would indicate a correct understanding of the teaching? go ahead and select all that apply. So our options are, I plan to place the humidifier in my bedroom. I should contact the clinic if my urine color changes. I will receive a prescription for an antiviral medication. Drinking cool citrus juices will be soothing to my throat. And 5, gargling with a warm saltwater mixture may alleviate my pain. The webinar for NSNA is not free. It is $25 for members and $35 for non-members. And the Columbus event is going to be November. It's like the 6th through the 9th. It's that first full week of November. It is the NSNA mid-year conference. We're going to be doing a mini review. So that Thursday and the Friday, we have 4 hours of dedicated review content. You can find out more information on NSNA's website. But in that case, we're going to be doing exam strategy on Thursday and focusing on content on Friday. So definitely join if you're free. We would love to see you there. Someone asked about the Seattle one. The Seattle one was back in April. It was so much fun. We had a great time, but they change every single year. So I don't believe, I think it's in Houston next spring. So it will not be back in Seattle, unfortunately, because we had such a good time. And again, this is the, we're talking about the NSNA in-person conference, which is in November. So that's, someone asked what Thursday. It is Thursday, November 6th through that Saturday, I believe, is the conference. So a little further away, and it's in SNA, not in SAA, to answer your question. All righty. Lots of good info about NSNA. They are our friends over there. Okie doke. So lots of great answers coming in. Way to go. And I am going to go ahead and jump to our answers. So our correct options were 1, 2, and 5. So why were these correct? The humidifier in the bedroom helps to soothe the throat. It helps to break up any secretions, kind of thin them out. 2, I should contact the urine clinic. Contact the clinic if my urine color changes, excuse me. This can signify acute post-streptococcal glomerulonephritis. So we do want to make sure we're notifying the provider. We would have to go in. This is a complication that we would have to have treated. And lastly, 5, that warm salt water mixture may alleviate my pain. Totally true. Warm salt water will help to soothe the inflammation, reduce pain, and the warmth of it too is going to be really helpful to an irritated throat. 3 and 4 were incorrect. So if you read through this really fast and you selected 3, I would challenge you to go back and look a little bit more in depth. Now, this says an antiviral medication. Remember, strep is bacterial. RSV was viral, but strep is bacterial. So we would not give an antiviral for a bacterial infection. So I bet for you guys who got that wrong, I bet you just skimmed through too fast and didn't read it in full. Lastly, option 4, citrus juices will be soothing to my throat. The cool may feel nice, but citrus is acidic. That's going to be painful. It's going to burn. It's going to cause discomfort. It will not be soothing. So we would not want to do that. All right, great job, you guys. Final question of the day. The nurse is teaching the parents of school-age children about the treatment of pediculosis cupitis or head lice. Which of the following information should the nurse include? Select all that apply. So our options are to wash your child's bed linens in cold water, to keep your child's fingernails trimmed short, to remove nits from your child's head using a fine-tooth comb, to treat all your household pets with a pediculicide, or to seal non-washable items in a plastic bag for 10 to 14 days. For everyone asking, we go live Tuesday at noon Central Time. All these are in Central Time. Wednesdays at 11 a.m. and 7 p.m. Thursdays at 11 a.m. and 3 p.m. Fridays and Sundays at 7 p.m. So lots of different times. If you are unfamiliar with our schedule, uworldnursing.com gives you a full view of that. So go ahead and check it out. Also, we do have a free webinar coming up. I know the NSNA ones are not free, but we have a webinar that we are putting on 9/22. So that's next Monday from 11 to 1 p.m. Central Time. It's our CLEXpert webinar. It is free and it is 2 full hours of free NCLEX prep content. So we're going to be covering key cardiology topics. We get a lot of requests for cardiac, as well as select all that apply exam strategy. It's going to be myself as well as the wonderful nurse Rebecca. So make sure you tune in on Monday, and we can put that in the chat. I think that we have sent the link before. I'll make sure to send it out too. But we'll put the link. It's free. You just need to register with your email. So we'll drop that link in the chat, and you can join us. Again, 2 hours of dedicated free content. Alrighty. And for anyone asking, let me make sure you guys all get that link because I want to make sure you guys join if you are able to. All right, give me 1 second. Alrighty. Bear with me for 1 second and I will get you guys all of the info that you need. Perfect. Okay, just dropped it into the chat. It's a bit.ly link. I'll drop it in a couple times. Sorry to spam you guys, but I want to make sure everyone can see it. It's a bit.ly link. Again, it's cardio and select all that apply answers. So make sure you check that one out. It just went out like 3 times. So hopefully you can all see it. Let me know if you can. Alrighty, good deal. So in this case, let's go ahead and jump to our answers. See lots of great answers and mostly 2s, 3s, and 5s. So way to go, you guys. I see a couple of you guys still saying you can't see it. Let me go ahead and, you got it? Okay, perfect. Good deal. I think I've been spamming the chat. So in this case, yes, 2, 3, and 5 are correct. Most of you guys got this correct. We do want to keep short fingernails because we're going to have itching with lice. We're going to have that pruritus. We want to make sure that we don't break or excoriate that scalp skin, which is a perfect opportunity for a secondary infection. So keep those fingernails trimmed short. We also want to remove the nits using a fine tooth comb. We do that at the scalp. We prevent worsening infection. This is an indicated action. And lastly, anything that's not able to go in a washer and dryer on the hottest settings, we're going to put in a sealed plastic bag for 10 to 14 days. If we can't kill those lice in a hot washer, we're going to try and kill them by suffocating them. So again, 2, 3, and 5 were our correct options. 1 and 4 were incorrect. So why is this? We wash things in hot, scalding hot water to kill the lice, not cold water. And lastly, 4, treat your household pets with a pediculicide. Pets actually cannot get head lice. It requires a human host, interesting enough. It's just like humans can get bitten by a flea from a pet, but fleas can't actually live on a human host. Some things do not translate from animal to human. So just so you know. Alrighty, and someone asked to explain option 4. Let me know. I hope that made sense to you. If not, I can explain it again by all means. We're going to jump to a QBank slide for all of our existing UWorld users. Here's how to tailor to get more questions specifically on what we learned about today. And for anyone that has not used UWorld, isn't familiar with it, this is just one of the many, many ways you can filter our questions so you can target exactly what you are trying to work on and improve. So here's a little sneak peek at our QBank on UWorld. Alrighty, so thank you so much for staying tuned. I hope that you all found this to be helpful. Thank you again for joining. We're going to be live again tomorrow at 11 a.m. as well as 7 p.m. on Wednesdays. And I want to make sure, it looks like a couple of you are still struggling with that link. We will get it out to you. Do not worry. We have a couple different ways. We're going to put it in the rest of the lives for the rest of the week as well. So if you weren't able to see it today, come back and join us in a following live and we'll make sure we get you that free 2-hour webinar link. Thank you so much for joining and have a fabulous rest of your week.